Acromioclavicular joint dislocations, classifications, and treatment. Disruption or dislocation of the AC joint occurs after a direct trauma on the shoulder, where there's disruption of the main ligaments joining the acromion to the clavicle. So in dislocations of AC joint, there's disruption of the main two big ligaments, the AC ligament and the CC ligament. The AC ligament is the acromioclavicular ligament. CC is the coracoclavicular ligament. It's a common injury, about 9% of shoulder injuries. It's more common in males and in athletes. It can be as a direct trauma or falling on the shoulder. So the main ligaments are the CC and the AC ligaments holding the clavicle to the cricoid to the AC joint. There's also motion in the AC joint, which can be gliding or rotation. There are stabilizing structures, which can be static or dynamic. Static are mainly the AC joint, which is responsible for the horizontal motion and stability, while the CC ligament is responsible for the vertical stability. The dynamic muscles are the main big muscles here, which is the deltoid and the trapezius muscle. So this is the vertical stability by the coracoclavicular ligament, conoid and trapezoid ligaments. As you see here, they have a broad footprint. Horizontal instability of the AC joint is through the capsule and strong ligaments, which are in the posterior superior part and anterior inferior part, and these are responsible for the horizontal stability of the joint. For our treatment, we follow the Rockwood classification, type 1, in which there is a sprain of the AC ligament, type 2, in which there is rupture of the AC ligament and sprain of the CC, type 3, in which there is rupture of both the AC and the CC with displacement of the clavicle superiorly, type 4, in which there is posterior displacement of the clavicle, type 3, type 5 is the same as type 3, but more displacement and tension on the skin. The last type is type 6, which is the subcoracoid type. To diagnose such injuries, we do an X-ray, standing position, and the beam is inclined about 15 degrees. This is known as the Zanka view. And we compare both sides, and we measure the distance between the coracoid and the inferior surface of the clavicle. Some authors and surgeons prefer weight-bearing X-rays to differentiate between the second and third type of Rockwood classification. Others do not agree because the dynamic stabilizers, which are the muscles, contract, and you will not make benefit from this type of view. But what is important is the Alexander view, lateral view, which is a cross-body adduction view. This shows if there's any displacement of the clavicle posterior. As you see in the slides here, there's dislocation of the dynamic forces of the clavicle posteriorly. So this is important to diagnose the DPT, which is the dynamic posterior translation, in which the clavicle goes posteriorly. So therefore, we're going to classify type 3 into two types. A, which there is a stable in horizontal direction, type 3B, where there is horizontal instability. As you see here, the X-ray shows the displacement of the clavicle posterior. This is type 3B. Treatment is mainly conservative or operative. Conservative in types 1 and 2, and this is by sling and local measures. Surgical, we follow the Rockwood classification for the types of fractures and dislocations and the type of treatment. So therefore, there's an algorithm of treatment beginning from type 1 and 2, whereas primarily it's non-operative by conservative treatment. Type 5, 4, 5, and 6, these are for operative treatment directly. So the dilemma here is on type 3. So in athletes, manual workers, or high demand patients, then we go for surgery. Otherwise, we go for operative, non-operative treatment, which is conservative treatment, and we follow the patient. Sometimes after 6 weeks, they still have some complaints and they are transferred into operative interference. This is for type 3. Therefore, there are two issues. First issue is early and late treatment. What is important? There's moderate evidence in the literature about early treatment, but most of them recommend early treatment. Others in a systematic review found that there's no difference between early and late treatment. Also, another issue is that we should diagnose type 3B. Otherwise, if all type 3 are treated conservatively, they found that 50% of them will have scapular dyskinesia, which means abnormal motion of the scapula on the thorax. This will end up with a sick scapular syndrome where there's pain and fatigue during movement. So surgical treatment, the aim of it is to repair the AC joint ligament and the CC ligament. And we have we have devices to help us to maintain the position of the AC joint until healing. These may be in two big groups, metal devices or suspension devices. Metal devices like the hook plate or the screw between the coracoid and the clavicle. They maintain the clavicle in space until there's healing of the ligaments. Suspension devices, mainly arthroscopically, which are used now, in which there is a suspension of the coracoid to the clavicle. This may be by synthetic material or biological, such as tendografts, or it may be dynamic by using the coracoid bone with its attached muscles directly on the clavicle. But what is important in this treatment is that we should consider treatment of the AC joint ligaments. So historically, most of the researchers were focused on treatment only of the acromioclavicular ligament. But recently, there's a great importance of treatment of the AC ligaments. Also, in a systemic review, they found that there's great improvement in clinical function after repairing the AC ligaments. Therefore, it's important to diagnose the DPT and early treatment of these cases by reduction of the AC joint in both vertical and horizontal planes. So there are mainly two groups which are used by most of the surgeons, which are the hook plates or the arthroscopic suspension techniques. The hook plate, in which you put the plate under the acromion, not in the joint, to maintain the position of the clavicle in relation to the acromion until there is healing of the ligaments. The advantage, we have perfect reduction in both vertical and horizontal planes, possibly of early post-operative movements. He can go back to work directly, low technical demands, no residual foreign body after removing the plate. The disadvantages that we do not treat glenohumeral co-pathologies, which are found in about 20% in patients above 45 degrees, and these are diagnosed only arthroscopically. Disadvantage that we should remove the implant in 4 months, and in some old generations of plates, there was a type of acromial osteolysis when they use the old type of plates inside the joint. So it's also important to know the type of plate you use. You should choose the plate which is outside the AC joint, and there are different heights so that you will not have over-reduction or under-reduction. The suspension devices, arthroscopically, they have advantages. First of all, very minimally invasive. Number two, that they can address the co-pathologies which are present in 20% of the patients. Disadvantages, there's more restrictive post-operative treatment. In some types of button use of suspension devices, there is retention of the implant, which may cause irritation. Also, there can be a type of fracture of the clavicle or the coracoid process during your technique, and this is present in about 20% of the patients. But in cases of suspension and arthroscopic reconstruction, it's also important to address the AC ligament. I will present some of the cases with the hook plate, and this is my experience in about 15 years. So this is a patient with dislocated AC joint type 3, was treated with the hook plate. And this is the approach, very conservatively. You do not dissect, you just try to reduce the AC joint in both planes and repair, as you see, the 3 sutures here of the CC ligament, which has a broad footprint, and then you close all the soft tissue sleeve over the plate. This is another case with dislocated AC joint treated by the hook plate, and the patient post-operatively can early mobilize with very good range without any pain and can go back to his work or to some jogging and very limited types of sports. And then the plate is removed after 4 months without any restriction of movements after removing the plate. He can go directly back to his sports. This is another case in which there is fracture of the lateral third of the clavicle. We do a CT scan to study the displacement, and then we can use the hook plate to reduce and repair the ligaments and close the soft tissue sleeve over the plate. So in conclusion, best results are achieved if there is early management in about 3 weeks, if there is proper choice of the hook plate, if there is reduction in the two planes, you should repair the ACZ and the CCA ligament, early rehabilitation, and removal of the hardware in 4 months. Thank you very much.